I was wondering if you could shed some light on how, more so from a nursing standpoint, because we always question this, but how should we deal with patients who come in for drug overdoses, specifically heroin, who want to leave before they've been seen by the physician or even after they've been seen by the physician?
Yeah, that's a tough one. So great question. And in case you didn't hear it in the back, so you have somebody comes in with an overdose. Let's say it's heroin, for instance, and then maybe they get their Narcan. Is that what you're talking about? They get their Narcan, and now they're feeling pretty good, and now they don't want to stay. Well, you have to meticulously document that they have the capacity to consent and refuse. And if they refuse, you probably need to release them. But I would document it well. If you think that there's a mental health issue, like they're suicidal or something, there's some other reason to remove decision-making capacity, then document that well and do that. But this is just like the diabetic that gets D50. I mean, there are different social situations, I get that, but oftentimes that happens, and I'm sure Jim would talk about that with EMS. My experience was when I was a paramedic, I finally got smart, and I would load them in the ambulance, get going down the road before I actually pushed the D50. Otherwise, they were refusing all the time at the scene. They're already home and they feel better. This is a similar corollary from a risk standpoint. And what I think is really cool out there, and I don't know what's happening in your state, but there's a lot of momentum on naloxone kits and these programs. And if they feel they're being judged, they're going to get arrested, they're going to flee, they're going to be out of there. Say, listen, we're not judging you. There's no personal bias here. We know you're not going to stop unless you tell us, and we'll get you into rehab. But we can even prescribe to you or even hand out a kit to you, and it has instructions in it on how to use it. And then maybe they're ready to go. And if you don't want any further care, we'll document you don't want. But can we do this? And then you've done all you can for them. And I think that's the best you can do. Does that help?
We have another question at the back.
Yeah, this is for Kevin as well. In my emergency department, we occasionally take care of intoxicated people.
Wait, before you go further, are you an alcohol center of excellence?
Oh, yeah.
I need to know what level you're at.
And I think that over the last couple of years, there was recently a case, I believe it was in New York, where an intoxicated person was in the emergency department. They left. I believe they were injured, and something occurred, and it basically came out that, that was the intoxicated person's fault. Do you have details on that case? Do you know that case?
I got a lot of details.
Give me some
That's great.
advice.
I'll try not to go into too much detail, but it's a great example, and I'm glad you brought it up. It's a great example of what not to do. So what happened was this guy came in intoxicated. He was also suicidal. That never happens, right? And well, they held him waiting for mental health placement. The mental health provider had already seen them. They're waiting for a bed. I think the bed was in the facility, actually. They didn't have the bed yet. So they're kind of holding him. And all of a sudden, he decides, I'm going. And they decide, they do their evaluation, and they think that they can let him go. And he gets hit by a car. He physically gets hit by a car, and I don't know, I think he just got badly injured. I don't think he died, but I don't remember all the details of the outcome. So ultimately, after this was adjudicated, they said that they did their due diligence, and this guy had the capacity to refuse and was able to leave. That if you practice based on that case, there's flawed logic there. You will not get that lucky again. Not only was he suicidal and deemed to require admission, or at least that he needed further evaluation before that decision could be made, he was still intoxicated. And so does he really understand and have the decision-making capacity to make a good and reasonable decision? I don't think he does. And by the way, just so all of us are on the same page, people who are committed to suicide will tell you whatever they need to so they can go commit the act. That's why we don't let them go. So I'm very familiar with the case. It was ultimately ended up to be a very generous outcome for the providers in the hospital, but I would recommend that if somebody's intoxicated and somebody's suicidal, that you're on the side of keeping them. Rarely, I mean, these people say that you're gonna get kidnapping charges and false imprisonment. There is not one case that I'm aware of a successful suit against a provider or a hospital where that has happened. Always err on the side of trying to take good care of patients and document well.
This could be for anybody on the panel. I just got a text from a friend who's a residency director, and he asked if there's a document or guidelines for risk management for common chief complaints in emergency medicine.
I know.
I can tell you that it's not part of the ACGME requirements for having an EM residency. You do have to teach to it, but there's no required documentation to have a residency program. That I know.
Like, do you have a guideline?
Do we have a guideline for how we teach?
Yeah, like chest pain, syncope, altered mental status.
Not specifically. We do have a curriculum that says we will teach the following: chest pain to include what used to be called myocardial infarction, is now ACS, PE, that kind of stuff. But it doesn't get any more specific than that.
There is a textbook, because I wrote a chapter for it, Chief Complaint-Based Emergency Care. Glenn Hamilton, Wright State, was the editor, and some parts of that had some risk management pearls. So I have to leave now, but I will see all of you who are going to tour UMC. I have to get there early to set up the tour. It's been an honor and a pleasure. Thank you again.
Thanks, Jim.
I'm not aware of any curriculum either. I won't spend a lot of time here, but there are some, I'll just say there's some good resources out there, but not necessarily built into curricula.
I have a question here.
Kevin, a question for you. We're seeing a big increase in our emergency department of furloughed patients from prisons, where they're releasing these patients, bringing them to the emergency department, dropping them off and saying, hey, just give us a call back and we'll come back and pick them up. But then we call them and hours later they're still not coming back to pick up the patient. Obviously, you don't want to have the guy in the jumpsuit sitting in my waiting room for a couple hours as people are walking through the door, but they have no personal belongings. They usually have nobody there. Any suggestions on how we can fix that?
This is a real tough one, but it happens often. I think law enforcement wants to rely on us, that they have pressure on them to not put somebody into one of their jail cells with a medical problem or who's going to have a bad outcome, whether they're too intoxicated, where they have an injury, and they just want the comfort of knowing we've evaluated them. So I get that side of it. The other side of it is I think they err way on the side of dropping those patients off too often. They burden us with them. Anybody who has had anything to drink or had a slip and a fall, they're coming to the ED. And I think the way to address that is not on a case-by-case basis, but dealing with, as leaders, dealing with law enforcement on the front end to say, what can we really help you with? And let's narrow down the scope of what we're doing. We are not a sobering center, and if you are, fine, then you can provide that service. If you're not, let them know that. They don't understand what we do, and they don't understand when they do that other people who are sicker and there more legitimately for the appropriate purposes are not getting care. So I don't know if I have a very good solution for you, but it is a national problem, and it is very frustrating during a busy shift. As you know, I don't have to tell you that. But I think we've got to deal with that from an agreement and policy standpoint on the front end.
In case you couldn't hear, he said he had that problem in Maricopa and did a face-to-face meeting with law enforcement officials and got it kind of worked out. So,
yeah, in our situation, I don't know if this is unique to Ohio or Northeast Ohio, but when the felon, the person is under arrest, then the prison, the system, us as taxpayers actually pay for their care. So it's not only a time, but it's also a financial issue. So we're pretty good about when the police bring someone in to asking, are they under arrest? At which point we do have to house them until the police come and pick them up. And if the answer is no, or the convenient dodge is, well, they will be when you're finished, that's a no, then I just take care of them and I discharge them. And then it's, obviously you don't want some child molester going back on the street. When we do call the police and give them the heads up, and say, hey, Mr. Jones is going to be going home soon. But really, if they're not under arrest, we're under no obligation to keep them.
Just add a quick comment there. I think that's great information too, but I would just throw out one additional piece of information. If they're under arrest, law enforcement must provide the resources to detain them. You are not required to detain them. They want them detained, and I think you need to have that conversation, well, policy-wise, but also on a case-by-case basis. Hey, just as Nick said, understand right away, is this person under arrest? Yes, they are. Where are you two going? One of you needs to stay, because if he goes, I'm not putting the staff in harm's way to hold him. Just understand that. So if you want him to be under arrest, go ahead and do it now and detain him and leave somebody here. And I think most law enforcement kind of get that, but some try and get away with leaving.
Yes, to Kevin. I appreciate the direction that the patients that don't need to be, we don't have an obligation if we treat their pain and send them on as far as driving. We just have to give them the instructions not to drive or perform hazardous activity. But how do you reconcile that if we've altered them with a dose of pain medicine? with the statement that we can't send them home if they're intoxicated and they're not able to make that decision.
Yeah, I think if they're impaired to the point where you can't discharge them at all, if they say, I have a ride, just like the person who's intoxicated but can have a conversation with you, does not appear to be severely impaired, they're not at risk. I kind of break these people, whether it's something we've given them or something they came in that they had ingested or that they used recreationally, in a couple different categories. The first is if they have a medical problem, we need to evaluate that. If they don't have a medical problem and they are so impaired by the substance that it is unsafe to send them home, either because they have no social support or, you know what, they're just too obtunded, then we can't send them because it's just not safe. And then another category, it's somebody who does have good social support. The parents are here for the 16-year-old. The kid is wide awake but clearly intoxicated, and they can take them home, and there's nothing medically wrong. I think if they're going to a safe environment, those are safe discharges. And I think the same as when we go ahead and treat somebody, oftentimes, most of the time when we treat somebody, we don't get them to a level of impairment that would prohibit them from safely going home, but it would prohibit them from safely operating a motor vehicle, which is what we're telling them not to do. And you can be more proactive with it. I just don't want, and I had to, with that list, I wanted to give you a sense of what's out there and give you some very brief pearls on it, but certainly we could have some more detailed conversations about that. But I want people to realize that where your level of obligation or the line of obligation generally tends to stop. And I've seen people being dragged out of cars and parking lots. I've seen people tackled in the emergency department. You can't do that stuff. And don't feel bad if someone lies to you, because it happens sometimes. Okay.
Okay, this is for Kevin again. Sorry, everyone's falling asleep around you. But no, I'm
not
only
Rick.
kidding.
Maybe Nick, but not. You see what I tell you.
Okay, so my question, and anybody can answer, it's regarding referring for follow-up. So we all have a call list, and I've been doing the same thing for over 25 years where, I look at the call list, I refer the patient that needs ortho follow-up. In the back of my mind, I know that if the patient doesn't have insurance or they're Medicaid, I'm going to probably provide the on-call ortho group and also a backup, a clinic where it'll be more affordable, because I know that the private practices are going to want $250 up front. So anyway, we had a discussion with our hospital, with healthcare attorney, who's like a very reputable healthcare attorney in the country. She's well known. And she recommended to us that we should not be doing what we're doing. We should be providing a list of all the possible physicians to follow up with. And I didn't agree with that. My senior partner, he didn't agree with it. We've been doing this combined for 55 years. So I just wanted, what is your thought on that?
Yeah, my thought on that is, I get where she's coming from. Well, if one fails, go to the next. But from a practical operational standpoint, the only thing that's going to differ on that list is what amount of copayment they're asking for. Not that, oh, well, yeah, we take all these people, it's not a problem. What I don't like about having a list is that you're not providing timed and specific instructions for follow-up. And that opens you up to further liability exposure. So you can say, we told them to see Dr. Smith within 2 days for this fracture after we reduced it. We told them to do that, or within 24 hours, as opposed to saying, we gave them a list of people to call. It's a much better and more defensible position to say we gave them an exact name and wanted them to go there. But I'm glad that you're being proactive, knowing that those people may not have the money to pay the copay, and we all have to understand that under EMTALA, they're not obligated to see them. They can charge the copay. And you have to have a hospital-level agreement where, hey, you're going to participate in the call schedule. We really want you to try and get some of these people in. You're going to give some charity care and some free care. We need people to do that to a certain degree. And that's where you can have the conversation that we have all had. We were up here recently, too, about the free care that we give. Matter of fact, by the way, the one that you don't want to take care of, we just took care of in the ED for free. So can you help us with this patient, too? And if you have to make phone calls to arrange follow-up, do that also. Others may have comments. We're good? All right. To answer your question? Okay, great. Thank you.
Well, kind of works out well. I have a question for everyone. Maybe each of your favorite one or two ideas on this thing. One thing we consistently come across hospital after hospital is more and more of what I guess we're calling task-oriented nursing. one problem kind of creates another. As I summarize the whole conference and think of different ideas for improvement, for example, Dr. Welch had mentioned the importance of interacting with the treating nurse and tell them, here's our plan, so that they can plan ahead. And that's a great thing, while perhaps a bit inefficient these days, where we also, one of the slideshows where they talked about, it's important for the physician to have a little space that's quiet. So you can do your thing, you can concentrate, you can use your dragon. The nurses each have their workstations. The hospital's encouraging the nurses to document at the bedside. Everybody's all over the place, and so you can run around all over the place trying to track down the nurse to talk with them, perhaps, or not. And then you also have variabilities in nursing expertise, because the freestanding EDs are taking all the best nurses away. And like Dr. Welch mentioned earlier, then you have Ashley with the navel jewelry sorting out your problems for you. And it's becoming more task management for the nurses rather than managing the overall patient, to where oftentimes we're seeing in emergency departments, the nurse is there, they see an order pop up on the screen, they go do the order, they wait for the next one to pop up on the screen, and they're just doing what the orders say in the computer. What are each of your favorite tools, projects, ways to further enhance that collaborative care, as well as elevates the nurse's thinking to manage the patient as a whole along with us, instead of just see an order and do it?
Sure. I related a little bit to what I was talking about earlier. What's evolved in emergency medicine is today we have residency-trained physicians who don't need to be overseen by the nursing staff. And yet we still have this system where every patient has to have a complete nursing evaluation, a nursing care plan. I go into situations now routinely with electronic medical records where the physicians never see the nurse's notes, because they see the patient and enter their notes before the nurse is done entering hers. And to me, that's an incredibly dangerous situation. I've been saved a lot of times by a nursing observation. In my interaction with the E&A group, my hope was that some of those thoughts could change. But I think at this point, it's become a turf battle where we can't seem to allocate the tasks. You know, the nurse does this amount and then you take over, but you don't duplicate each other. I had no listening for that at that level.
Yeah, I don't think this is a problem related to the freestanding EDs. This is clearly a unintended or potentially intended consequence of the EMR. You know, we have a great group of nurses we worked with a long time. They bail me out all the time, but we would usually talk about every single patient all the time. Hey, what do you think about this one? What are we going to do? Right now, we're all talking to the computer. We're not talking to each other. And we try to get around that, particularly with sick patients, where we all swarm in the beginning and see the patient together and talk about what we're going to do, and that informs the patient. But that, in the age of computers, doesn't happen as much. And I think that's really bad related to computer. And the person who hates EMR the most is Rick, but it's not helping us at all.
And that's the question. What solutions have you guys come across so far?
You know, I'll add a little bit to what Nick said, and he and I feel exactly the same on this. What happens during downtime? The EMR is getting updated, and you can't use it anymore. You communicate. And that we go back to the way we used to communicate. There could be some positives of the EMR, I've yet to find them, but there could be some, but we've certainly had some negative outcomes with that. And one solution that at least I've used in my own practice, and maybe we could more, scale this to a larger group, is when you put orders in the computer, I think you need to go to the nurse taking care of that patient and say, listen, here's what I just put in the computer, so that when they know that this is what you ordered, when they see something that's aberrant that actually ended up on somebody else's, or they don't see the order, they'll let you know, because all the nurses should really know. It's a 5-second conversation. Hey, I just saw the person with abdominal pain and 2. They're yours, right? Yeah. So we've got some IV fluids. I'm starting some antibiotics because they have a fever. And we're going to go ahead and do a CT, no oral contrast, and some labs and some urine when you can get to its pain meds. And specifically what that is. They'll know the plan. When you don't, and particularly when you have a less experienced nurse, if there's something that's out of place, they may not recognize it, and I've seen that happen. Great. I'll be efficient. Here are the orders. It pops up. You're over there. They're over here. They take off all the orders. And 2 hours down the road, you find out that the patient with abdominal pain just got Lovenox. For what? And the person who needed the Lovenox didn't get it. So I think communication is key.
I think also there's this idea that some of the nurses feel compelled and that their license is dependent upon doing a nursing assessment and coming up with a nursing diagnosis. And I think that those kinds of things often get in the way, but I think that the nurses that feel that way feel that it is a requirement of their job. Now, where it says that every patient requires a nursing assessment and a nursing diagnosis, disorder characterized by lack of breathing, is we never, frankly, had to deal with that because we didn't really have any particularly militant nurses in terms of this is my job, I got to do my job, you got to do your job. We're co-equal professions. I got to do my job. You just step back, doctor. And fortunately, we didn't have any of that. But I do know that people have had to deal with it, and it's tough because what it comes down to is, this is my license. I'm required to do this, and it's hard to kind of come back against that because they're protecting what they perceive to be their license in terms of doing these assessments. Frankly, we would often see people without the nurse ever seeing the patient. And you know that when a kid comes in, a little febrile kid comes in, they're doing something else, you go in that room, you're basically done the exam, and it's time for aftercare instructions, which you're going to do yourself and you're going to give to the mom, that this nurse never really ever saw the patient. Now, some places that would be viewed as, that is outrageous, that should not happen, it's bad. But our place, it was good. The doctor saw them. They were evaluated, diagnosis made, out they went, no harm done. So it really depends, I think, a lot on the philosophy of the nurses. They're the drivers of this.
All right, my friends, I hate to tell you this. We need to be at our end here because I've got to let you grab some lunch, those of you who are going on the tour. If you have some just burning questions, why don't you come up to the front and you can ask them, kind of offline. And thank you so much for coming. Thank you, panel.